Assalamualaikum everyone, and my topic of presentation is alarming increase of hypervitaminosis and vitamin D toxicity. I don't- I have no conflict of interest or commercial bias, and I'm thankful to my co-author. So starting from the background, as we already know that replacement of vitamin D for maintaining sufficient bone health is very necessary, and achieving balance between optimal and toxic levels is equally important. The trends of prescribing vitamin D preparation for non-specific body aches and self-medication with over-the-counter vitamin D supplement has increased significantly, and practice patterns of physicians in treating vitamin D deficiency vary due to lack of clear guidelines on optimal dosing regimen and availability of different vitamin D preparations. In the past, vitamin D toxicity was considered a rare adverse effect, and the importance of vitamin D toxicity has been underestimated and under-recognized. But recent trends have showed that prevalence of hypervitaminosis and toxicity has increased significantly. So the objective of my study was to investigate the frequency, clinical features, and pharmacological factors of hypervitaminosis and vitamin D toxicity. So evaluate the role of vitamin D supplementation in vitamin hypervitaminosis and vitamin D toxicity. We conducted two separate studies. First one was in 2018 in children who were registered for clinical consultation at AKU with serum vitamin D levels of more than 50 nanogram per ml. And second study was conducted from April 2020 to March 2021 in subjects in all subjects with serum vitamin D levels of more than 150 nanogram per ml. So these are the results. In 2018, total 1,18,149 subjects were tested for vitamin D levels, and there were 602 children with vitamin D levels of more than 50 nanogram per ml. And of these children, 197 visited AKUH for clinical consultation and had history of vitamin D supplements and medical records. In second study, during this period, over 1 lakh subjects were tested for vitamin D levels, and 151 children and 213 adults had vitamin D levels of more than 150 nanogram per ml. And in final analysis, in final study, 78 children and 108 adults were included after satisfying the exclusion criteria. So in the second study, majority were females, and mean age of children was 2 years and mean age of adult was 41.4 years. Majority of children in first study were taking supplements because of aches and pains and developmental delay, and only 24.8% subjects were tested for vitamin D levels and had vitamin D deficiency. There were similar findings in second study. Only 24.4% children had vitamin D deficient or insufficient levels. The rest were taking supplements because of delayed growth or short height or delayed milestone or walking or bone pains. And in adults, in second study, vitamin D deficiency was noted in 32.4% subjects. The rest were taking supplements because of bone pain, renal insufficiency, and immunity purposes. In first study, 65.83% children were taking capsule and drops, and 34.17% subjects were taking mega doses in form of 2 lakh IU and 6 lakh IU vitamin D supplements. So 14.7% children took a mega dose of 6 lakh IU once. Rest of children were taking different preparations for months and years. In second study, 82.1% children and 68.5% adults were taking supplements in form of oral supplements, followed by intramuscular, and there were also subjects who were taking both oral and intramuscular supplements. These are details of supplementation strength in children. The majority of children were taking supplements in form of drops of 400 IU and 6,666 IU per drop, followed by mega doses of 2 lakh and 6 lakh IU. And there were also children who were taking supplements in combination of mega doses and drops. And time duration of supplements from varied from months to months and years. The majority of adults were taking supplements in form of mega doses of 2 lakh IU and 6 lakh IU, and majority of subjects, 53.8%, took supplements for 2 to 3 months, and there were also subjects who were taking supplements for more than 1 year, and they were using different frequency of weekly and monthly supplements. So total cumulative vitamin D supplements who were taken by children was 4,20,000 IU with 12,066 IU per day, and in adults total cumulative vitamin D supplementation was 16 lakh IU with 27,066 IU per day, which is very much higher than recommended by international guidelines. And majority of subjects were prescribed by physicians, and only a few subjects were taking supplements were self-medicated. Only 30 in first study, only 30% children developed symptoms of hypervitaminosis, and in second study, 23.1% children and 29.7% adults had developed hypercalcemia. So coming to the conclusion, there is a rising trend of prescribing vitamin D preparation for non-specific body aches in this part of the world. Health effects of toxicity can be serious and need prompt diagnosis. The condition can only be prevented by spreading awareness among healthcare providers regarding the toxic potential of vitamin D doses, careful use of vitamin D supplements, and consistent monitoring of people during supplementation. There is a strong need to have our own guidelines regarding dosage and dosing intervals for correction of vitamin D deficiency, if there are no published guidelines from Pakistan with the available preparation. Thank you.
Dr. Sahab, may I ask the title of your study and conclusion, do they match?
So the title of my study was to evaluate the role of vitamin D supplementation in developing vitamin D toxicity and hypervitaminosis. And
Dr. Siraj, your objective was to investigate the frequency and clinical features, right? And now look at the conclusion that you had in your slides. Do they match?
I think the conclusion is matching with the title, because we noted that due to the mega doses of vitamin D supplement, the children and adults are developing vitamin D toxicity. So there is a strong need to prepare to have our own guidelines regarding the doses of vitamin D.
Thank you very much, Dr. Siraj Muneer. Before proceeding to our presenters who will be presenting physically here, I would announce few rules for physical presentations. It will be a 7-minute presentation in total, and at 6 minutes we will give a soft reminder, and after 7 minutes there will be 90 to 120-second question session by judges or respected chairperson or co-chair. Now I would request Dr. Mavish Iftikhar. She is from Services Hospital Lahore and working as Assistant Professor of Endocrinology. Please come for her presentation. Fracture risk prediction in Pakistani population using South Asian Modified Fracture Risk Assessment Tool, FRAX model.
Bismillahirrahmanirrahim. Assalamu alaikum. This is Dr. Nawazish, Assistant Professor Endocrinology, SIMS. First of all, I want to thank Endo Colloquium for providing me with this opportunity to present my work from this prestigious platform. Fracture risk prediction in Pakistani population using South Asian modified fracture risk assessment tool. Let me introduce with my team first. Professor Khadija Irfan Khwaja, Professor Endocrinology, SIMS, Professor Aisha Habib Khan from Agha Khan University, Dr. Amna Rizvi, Associate Professor, SIMS, myself, and Dr. Zahra. This is our hardworking team. And we have done this in collaboration with Agha Khan University and Global Health Research Unit, a project of Imperial College of London. So the osteoporosis has become a global epidemic. The magnitude of problem may be because of the increased population, increasing aged population, and figures are alarming. More than 200 million people across the world are suffering from this disease. The International Osteoporosis Foundation figures say that 1 in 3 woman and every 1 in 5 man will experience fracture in the lifetime. So it's a great financial burden on our health system. What is the key? Prevention is the key. And it is difficult because of the silent nature of disease. People present late, present with fractures. So what is the key? It is to prevent, and for prevention, screening is an important thing. So we identify population at risk by using screening tool, which is fracture risk assessment tool. So it is the objective of my study to determine the fracture risk in a community setting in Pakistan using FREX modified model. Why modified? Ideally, the data of 8 specific incidences of fractures and death should be country specific. But these figures are rarely available. So the original FREX model has been developed from registries from European population, Caucasians, but the modified FREX model that was developed for Indian ethnicity in Singapore can be used as a surrogate marker in Pakistan. So we have used this, the design. It was a cross-sectional community-based study. The duration of study was from September 2021 to June 2022. And we have taken sample of 8,000 patients, people, and the sampling technique was non-probability convenient sampling. Participants were recruited from the field surveillance sites of Lahore. We have taken men, male and females more than 45 years of age. And we have excluded pregnant and lactating women. The study was ethically approved by IRB SIMS, and after informed consent, online modified South Asian FREX questionnaire having 12 parameters have been asked by trained community workers. And we have put this data on, for statistical analysis in SPSS version 25. So these are few pictures while in field. We can see that our hardworking community outreach teams. So we got the results. The baseline characteristic of this 8,086 people, mean age was 52.54 years. Females were 66.3%, males were 33.7%, mean BMI was 28.69, and post-menopausal females from in this 5,346 females were 55.1%. The mean major osteoporotic fracture risk in female was 3.34%, and in males it was 2.32%, while the mean hip fracture risk in female was 0.86 and in male was 0.61. That we got from the study. The hip fracture risk was which was more than 3%, which is threshold for the treatment in 6.6% of the population. So our total Hoover population, 6.6% people had more than 3% risk. And major osteoporotic fracture risk was 9%, 7.5%, 83%, 83.5% as high, moderate, and low risk. So there was a significant positive association of severe major osteoporotic fractures with age and negative significant association with BMI. The surrogate modified Fricks model, it provides an opportunity to determine fracture probability within the Pakistani population and can help guide us decisions about prevention. These are the references which I have done the literature search while making my presentation, and there is no conflict of interest, and financial funding is by ongoing GHRU project. That's all from the study. Thank you.
I would like to ask many questions. First of all, how did you calculate the sample size?
Sir, basically, sir, basically, this is the our team for this ongoing study, and we have statisticians with us, and we have done this because we needed the larger sample size because we need it.
Which formula did you use? Simple.
Sir, the exact formula is difficult to remember. It's not in top of my head. I can provide you with because I have a material.
And this was a population-based study.
Yes, sir. Community-based study.
Community-based study,
Yeah.
done only in one part of Lahore. And how can you generalize the results for whole Pakistan?
Sir, actually, I have taken the cross-section from this ongoing study because this data is a cross-sectional one, but this will be ongoing. And we will reach all the area of Punjab, rural and urban areas because this is...
Which statistical model did you use?
Sir, these are, first of all, we wanted to divide the population in high, moderate, and low risk. So, first of all, we have calculated the frequencies for the...
Thank you, Dr. Mavish.
Thank you, sir.
Excuse me, I have a question also. You said that age was related to osteoporosis risk and BMI was not related. So as very rightly pointed out, you have not used any statistical model. So you cannot say that age is related and BMI is not related. Because in statistical modeling, then you do the advanced analysis and then you can say that this factor is a risk factor for this and this factor is not. And the one thing is that age is not a modifiable risk factor, but BMI is.
Yeah.
So you should not give this statement, okay, on the basis of this very basic analysis.
So, madam, this is very important point. I will keep in mind. Actually, this is was BMI was negatively associated as it was predicted also because low BMI is a negative association with. Thank you, ma'am.
Thank you very much, Dr. Asla. Now I would request Dr. Azhar Nasim. He is from Nephrology Department, Services Hospital, Lahore, and he will be presenting on prevalence of bone mineral disorder in hemodialysis patients, a single-centered study of local population. Please join.
Bismillahirrahmanirrahim. My name is Dr. Azhar Nasim, working as Senior Registrar Nephrology Department, Services Hospital, Lahore. Title of my topic is the prevalence of bone mineral disorder in hemodialysis patient. It is a study, single-center study of overpopulation. Brief introduction: chronic kidney disease. As we know, there is a gradual decline of the function of the kidney function over the period of months and years. Globally, 5 to 10% patients have CKD in any form, from mild to severe. Mineral bone disorder is a chronic kidney disease that affects the bone, hearts, blood vessel, and of the CKD patient. And CKD MBD is characterized by the changes in the hormones named calcium, phosphorus, vitamin D, and intact PTH. This is a diagrammatic representation of CKD MBD. You can see on the one side, this is laboratory abnormalities of calcium, phosphorus, PTH, and vitamin D that affects the bone remodeling, named renal osteodystrophy. It consists of the high turnover bone disease, low turnover bone disease, osteomalacia, and mixed osteodystrophy. And it affects also the vascular calcification, and that leads to ultimately the cardiovascular events, fractures, and mortality. The objective of my analysis is the prevalence of bone mineral disorder in our population. After approval of IRBs, we have conducted a study at the Nephrology and Dialysis Department Services Hospital. Now, we have, this is an observational cross-sectional survey of 88 patients. Inclusion, both gender are including in age between 18 to 16 years and of duration dialysis more than 6 months. And we excluded the patient having acute infections, malignant lesions, or thyroid disease. This is demography, 55% are male and 45% are females. And we use this KDOKI guidelines for the categorize this renal osteodystrophy on the basis of intact PTH level. Intact PTH level on this side, in the values between 0 to 150, it is the low turnover bone disease, and 150 to 300 is the normal turnover, and more than 300 PTH level, it shows the high turnover bone disease. Now this is results. In my study, the 73.9% patient has high turnover bone disease, and 30.6 patient has low turnover bone disease, and rest of the patient fell in the normal turnover bone disease. This is the prevalence of normal intact PTH level with the calcium and phosphate level. You can see this is calcium's levels here and phosphate level here, and this is the normal low turnover bone disease in the green line, and the normal turnover, and this is the high turnover. You can see this high turnover and normal turnover bone disease, the calcium level remain in the normal range in most patients. When the calcium is tend to increase in a dynamic bone disease because of reduced osteoblastic and osteoclastic activity, and this is the free calcium that is available for extra skeletal calcification. And in the same way, in normal turnover, in most patients, phosphate remain normal. But as in high turnover bone disease and adynamic bone disease, phosphate level will increase due to the dietary incompliance over patient and uric on dialysis and inadequate dialysis sort of. That's why this is phosphate is available for excess skeletal calcification for CKD, MBD, morbidity.
Thank you very much, Dr. Azhar. Now I would request Dr. Nawazish Zahra, and she is from Agha University Hospital, Karachi. She will be presenting on Enlightening Patient Perception Through Education, a pilot project on models of care for secondary fracture prevention. Please join us.
Assalamu alaikum and good morning, everyone. I'm Dr. Nawazish Zahra, working as a research associate in Chemical Pathology Department of Laboratory Medicine at Agha University Hospital. And today I'm going to talk about Enlightening Patient Perception Through Education, a pilot project on models of care for secondary fracture prevention. I have nothing to declare here. Now, as we all know that fragility fractures are the most feared outcome of osteoporosis, and it affects 1 in 2 older females and 1 in 3 elder males. Internationally, to prevent the fragility fractures, there are multiple care of models integrated in their healthcare system. But in Pakistan, unfortunately, we don't have any model of care to prevent the secondary fractures. So a model proposed by Ganda et al. Has been introduced at Agha University Hospital to determine the feasibility of model of care for secondary fracture prevention. It is a multidisciplinary project that involves orthopedic consultants, rheumatologists, family physician, and chemical pathologist. Now let's have a quick review of the types of model proposed by Ganda. It has the 4 types: type A, type B, type C, and type D. In type A model, we provide the education regarding osteoporosis and fragility fractures to the patients and offer some radiological and biochemical investigations. And after that, we offer them a rheumatology appointment. In type B model, the education is provided to all the patients, and we have asked them to go to their family physician and for their osteoporosis treatment. In type C model, the education is provided, but we offer an appointment with family physician at the Community Health Center of Agha University. In type D model, only education is provided to all the patients at the time of discharge. Now, this study is started in November 2021 and it will end in 2024. So it's an ongoing project at Agha University Hospital, and we include the more than 50 years of age males and females. all those male and female who had a hip fracture and admitted to the Agha Khan hospital, and their age is more than 50 years, and females who are post-menopause, they are included in this study. All those hip fracture patients that encountered through road traffic accidents and their age is less than 50 years, they are excluded. So it is intervention based. We have different types of intervention in this model. We have a 6 weekly clinical case-based discussions and quarterly clinical audits and our regular FLS fracture lesion service members meetings. Challenges encountered. We have faced different challenges at different stages of the project, but one of the biggest challenge was obtaining the consent from the patient to recruit for the study. So to overcome this challenge, a meeting of members for fracture lesion service was set up on 23rd of March. Now the objective of the study: to evaluate the educational impact of 2 different methodologies of delivering the information on the outcome of consent rate for participation in the care path evaluation. For this objective, we hired the PDS cycle, which is called the Plan, Do, Check, Act cycle. In plan, our meeting was held on 23rd of March with the members of Fracture Lesion Service. And it was suggested that the provision of the comprehensive education material regarding the prevention of osteoporosis and fragility fractures was given. And research officers should spend 15 to 20 minutes with the patient to explain all the education methodologies and answer their queries. And act as to compare the results. So there are 4 types of educational material that comprises of 4 flyers. The first flyer, it's regarding with the fall prevention methods. The second, it discusses the healthy food for bones, their daily required amounts, and the nutrient sources of the calcium and vitamin D. And in this, we talk about some exercises. Now, we also provide a leaflet about the osteoporosis, in which we explain that what is osteoporosis, who can get the osteoporosis, what are the outcomes of the osteoporosis, how can we prevent the osteoporosis. And all these flyers, they are provided in English and as well as Urdu languages, and patient can take these to home. After spending 15 to 20 minutes with the patient, the refusal rate has declined to 34%, and the consent obtained rate is increased to 65%. After getting these results, another meeting was held among the members of FLS, and it was decided that the nursing healthcare professionals should actively engage in this model. And for the engagement of the nursing healthcare professional, it was important to educate them regarding osteoporosis and fragility fractures. So for this purpose, we arranged 2 seminar series in which international speakers was invited, the Kate and the Robin. And at the national level, for the further improvement of the orthogeriatric healthcare, the Fragility Fracture Network Pakistan, it was launched on 20th of January. Now the next steps. The next steps are very important. It is for the awareness of masses. We can aware the masses for their health-seeking behavior from the informative flyers, social media, and media on the programs for their bone health. And for the education, more educational opportunities should be offered to all orthopedic consultants. More general physicians should involve, and the nursing healthcare should involve through CME webinars and web-based learning and articles. Now, the development of the simple clinical pathway for the evidence-based guidelines are important for the optimal care of the patients. Our study is funded by the University Research Council at Agha University, and the team members are Dr. Nawazish, Zahra, I'm the research associate, Dr. Aisha Habib Khan, the PI of the study, Dr. Shahryar Nuddin, the co-PI, Dr. Tashfeen Ahmed, and Dr. Masood Umar. Dr. Mahmood Riaz is the rheumatologist, Dr. Saleh Tariq, the family physician, Nausheen Aftab, our nurse, healthcare nurse, to facilitate this study. These are the few references, and thank you.
Dr. Nawazish, may I ask what is the difference between a quality improvement project and research?
Yes. The quality improvement project is to improve the quality of the health of the community, and research is the same, but research has always shows some statistics and some results.
Was this a QI project or research, what you presented?
It is a research project, and it is a new project, a new kind of project that is evolving now in Karachi at the regional level. And you know that fragility fractures, it is the most neglected part, and the osteoporosis is the most neglected part. And for the other topics, we have some literature at our level, no? At our national level. But in osteoporosis and fragility fractures, when I did the literature review, the data shows the paucity, that there is a paucity in the fracture registry. There is a paucity in how many patients are getting, how many could have the secondary fractures, how many patients are admitted with secondary fractures. So this is the study. That's why we did this. Thank you.
Thank you, Dr. Nawazish. Excellent presentation. Regarding the final judgment decision, and the results will be announced in the last session of the conference. Now I would request our respected chairperson, Professor Dr. Ahmed Bilal, for his brief valuable comments.
I would request my co-chair to comment first.
I congratulate Dr. Khadija and her team and Agha Khan University to organize such a great event on the bone diseases related to endocrinology and all that. That was a good session for free paper session. And importance of bone diseases, we cannot rule out that. And the first paper, which was about hypervitaminosis, I would comment on that, because hypervitaminosis is, I think, that is underdiagnosed, still underdiagnosed. The reason for being is prescription of vitamin D in unindicated cases. So whenever you see a prescription by a general physician or by a GP or by a rheumatologist or by an orthopedic, that might not be complete without the prescription of vitamin D. I think the lesson should be taught to our colleagues. They already know this, but because of the pharmaceutical companies and all that, I think though we are having a deficiency of vitamin D, but unindicated prescription of vitamin D, that should be avoided. Personally, I never prescribe vitamin D unless I do the vitamin D levels. There are some conditions, as you already know, that chronic renal failure and all that, we need vitamin D supplements. But unindicated vitamin D deficiency, vitamin D supplement, they should be avoided. Then I would comment on this last presentation. The importance of education, that we cannot rule out that. That is very important. I think that is a very good step taken by the Agha Khan University to teach the patients regarding the secondary prevention of fractures. Then I would hand over the mic to Professor Bilal. Thank you.
Thank you very much. मैं थोड़ी सी नॉन कन्वेंशनल बातें करना चाहूँगा. प्रोफेसर खतीजा इरफान, ऑब्वियसली आपकी बहुत मेहनत है और आपकी वजह से टू स्टार्ट विद अ रिसर्च टॉपिक, कॉन्ग्रेचुलेशंस. और दूसरा जो अच्छी बात इन्होंने की है, उन्होंने ये किया है कि एक टॉपिक के ऊपर कंसोलिडेट कर लिया है हर साल को. तो मेरी हम्बल सजेशन ये होगी कि अगर हम एक अच्छी क्वालिटी रिसर्च चाहते हैं नेक्स्ट के अंदर, तो जिस तरह हर इदारे में एक प्रेसिडेंट होता है, एक प्रेसिडेंट इलेक्ट होता है, तो आप नेक्स्ट ईयर 2 नेक्स्ट ईयर्स के प्रोजेक्ट्स अभी से अनाउंस कर दें कि नेक्स्ट ईयर आपकी कॉन्फ्रेंस किस टॉपिक पे होगी और उससे नेक्स्ट ईयर किस पर होगी, ताकि जो लोग रिसर्च में उसमें आना चाहते हैं वो अभी से उस पर वर्क शुरू करें, बजाय इसके कि वो बिट एंड पीसेस उठाएं ऑलरेडी में से और उसमें से फिर वो चीज़ें हो जाती हैं. इसके अलावा मैं आई वुड से हैट्स ऑफ टू माय वर्दी जजेस कि आपने इतने प्यारे प्यारे चुपते चुपते और अच्छे सवाल किए थे कि आई होप कि हमारे जो प्रेजेंटर्स हैं वो यहाँ से बहुत सीख के जाएंगे और नेक्स्ट टाइम व्हेन दे कम टू द फोरम्स तो दे विल बी more prepared and more enlightened. And with all this, with prayers that ultimately it should bring some good to the community. Thank you very much.
I'm very grateful to Professor Dr. Amina Hussain and Professor Dr. Ahmed Bilal for their very valuable comments. And I would request our co-chair and chair of the session to please come forward for certificate distribution. And I would request our very honorable judges one by one to please come onto the stage to receive the certificate. Request Professor Dr. Khwaja Irfan Wahid, please sir come on the stage to receive the certificate. Professor Dr. Arif Nadeem, sir, please join us on the stage for certificate, please. Professor Dr. Shehzad Anwar, sir, please come on the stage for certificate. And Professor Dr. Afsha Shahid, madam, please join us. I would also request Professor Dr. Ahmed Bilal to present a certificate and token of thanks to our co-chair of the session, Professor Dr. Amina Hussain. Madam, I would request but the Principal Services Institute of Medical Sciences, Professor Dr. Farooq Afzal, sir, please come on the stage and present a shield and token of thanks to our chairperson of the session. I would also request Professor Dr. Ahmed Bilal to please present a token of thanks to Professor Farooq Afzal. I would request for a certificate for myself, please. I am very grateful to all our worthy professors, judges, chair, co-chair, chair, and principal sir for joining us for the first session, free paper presentation. With this, I conclude the session and I request Dr. Amna Rizvi to please come on the stage for inaugural session. Dr. Amna Rizvi, please.